Hi, everyone. Welcome to the Food and Agriculture Committee March call. We're really excited to have a great presentation lined up advancing health justice for farm workers. And we have two amazing speakers, which Matt will introduce shortly. But I just wanted to do some housekeeping items at the top of the call. So, as you know, we are recording and we will send out the recording link after this call to all those that registered. We are also offering one nursing continuing education for this webinar. And in the follow-up email I send, there will be information on how you can obtain that one nursing CE. And I will be sending that email out in the next couple days, 2 to 3 days. So just so you know, it might take me a little bit of time. But with that, I just want to say welcome, and I'm going to turn it over to Matt Lindsley, who is one of the co-chairs of the Food and Agriculture Committee.
Why, thank you, Kara. Great introduction. Awesome to kick us off. So, I am pleased to introduce our two speakers. We're going to start with Amy Liebman. She's the Chief Program Officer at the Migrant Clinicians Network, where she leads national programs advancing environmental and occupational health and health equity for farm workers and other underserved communities. She brings decades of experience working alongside clinicians to address workplace exposures, pesticide safety, climate impacts, and other environmental detriments of health. Amy is a nationally recognized leader and educator on farm worker health, worker safety, and health justice, with a strong focus on practical solutions at the intersection of vulnerability, health, and migration. Welcome, Amy.
Thank you.
We also have with us another speaker who we welcome, Enadelia Basurto, who's also known as Ene. Hene is a community health navigator at Migrant Clinicians Network. She has prior experience as a medical assistant at the University of Texas, Rio Grande Valley, where she provided direct patient care. As someone from a migrant farm worker family, Hene brings personal insight and cultural understanding to this work, having served on the front lines during the COVID-19 pandemic, supporting testing and vaccination efforts at multiple community sites. Welcome, Amy and Ene.
Thank you.
Thank you. So we're really excited to be here with you all today. And what Matt asked us to do in putting together this presentation, he just said it would be nice for us to just go a little deeper into how we ended up working with farm workers and the work that I do in the environment and the work that NA is doing in Health Network. So I'm gonna just hand it over to NA just to do a little deeper dive as an introduction into her wonderful self, and then I'll tell you a little bit about myself, and then we'll dive into the presentation. So NA, why don't you go get us started?
Yes, thank you, Amy, and thank you everyone for being here. I'm so excited also as well. To start off, I want to share a little bit about myself. I am located in Texas, in the south in the Rio Grande Valley, and I do come from a migrant farm worker family. I worked as a migrant farm worker moving from Texas to California up until 2019. While I was moving between states, I obtained my medical assistant license in 2020. I did have the opportunity to work with UTRGV, the University of Texas of the Rio Grande Valley. And during COVID, administrating vaccines, supporting testing efforts at multiple community sites. Later on, I had the opportunity to join the Migrant Clinicians Network, which I am very grateful to be a part of this team because MCN aligns with both my professional and personal mission. So, yes, that's a little bit about myself. And thank you, Amy, and I'll pass it back to you.
Thank you, NA. And this is the first time that NA and I are presenting together, so we're both very excited. And just a little bit about my background. I've been with Migrant Clinicians Network since 1999. And prior to that, I got my career start along the US-Mexico border, not far from where NA lives now. And that is where I felt like, even though I was postgraduate school, that's where I really felt like a lot of my learning began. And what I did on the border was I worked in a binational program. It was right after NAFTA had passed. And if we remember when NAFTA passed, NAFTA was about free trade and ignored the environment and ignored the free movement of labor. And so at that time, there were literally thousands of people migrating within Mexico and people coming to the border to work in maquiladoras. And the population growth at that point was really intense. And so many people at that time began living in unincorporated communities called colonias, where they were living without running water and sewage systems. And so I was fortunate enough to work with partners from Mexico who really taught me everything about work on the border, to do one of the first community health worker programs in the US that focused on environmental health, where we talked about safe water storage and hygiene. And it was a really impactful program where we were helping people who were forced to store their water to help them store it safely using a community approach to help them with their water and sanitation needs. From there, I learned a lot about the environment. I learned a lot about immigration. My background was in Latin American studies and public policy, and I felt like that on the ground work for 5 years was really pretty critical in framing the work that I did when I came to MCN. And when I came in 1999, we had had some major progress with the environmental justice movement. But by 2000, the environmental justice was being called, let's focus on children's environmental health and not call it justice. Let's not talk about workers, as the administration changed. And so I began developing an environmental health program within MCN, and then really began looking at it much more broadly in terms of environmental health, environmental justice, occupational health and safety, and climate justice. And so for many years, I grew those programs at MCN, and I'll talk a little bit more about MCN later on in the presentation, but really began to do in-depth partnerships with community health centers, a lot of advocacy, and other types of resource development and programming to improve the worker health and safety. So that's a little bit about NA and myself, and I'm going to go ahead and share my screen now and go through our presentation. Let me see, share. All right. Can you see my screen okay?
Looks good. Amy,
Okay,
question.
great.
Should we save questions for the end? Is that your
Yeah,
style? You prefer
if
to do
there's,
that?
I can't see the chat now because I'm in presenter mode. So if there's a pressing question that you want to stop us, go ahead. If not, we'll save it to the end.
Okay.
Um, And just like in honor of the nurses that are here today, we're starting off with a picture of Sister Eileen, who was a really important nurse in the Delmarva region of this country, and a mentor to me when I moved here to the Eastern Shore. So I love that we have this picture of Sister Eileen to start a discussion today. Anyway, she's just an amazing woman. Okay, NA and I introduced ourselves. So I want to start off with just a tale of two injuries to get us grounded. And we're gonna just go to Maine, the state of Maine for a moment, and we're gonna talk about two workers there. The first worker is a paper mill worker. And one day at work, this paper mill worker severed his flexor tendon on one finger. He was seen right away at an emergency department, and then ultimately had surgery. Because this worker was in a union, he was and had workers' comp, but not, was in a union and had workers' comp. And the workers' comp paid for the medical care that the worker received, and also helped pay for part of his salary while he was out of work. The workers' comp also helped the employer to provide an accommodation so that the worker could work until he was fully recovered. And after 3 months, this worker had indeed fully recovered and was back to his normal tasks. A little bit outside of the area where this paper mill worker was employed, there's a broccoli farm. And broccoli, we grow it in the spring or the fall, and when we're harvesting it, it's usually cold. And then this day in Maine, it was very, very cold, so it was hard to feel his fingers. And this broccoli worker had a very sharp knife and was moving very quickly. And as he was harvesting the broccoli, cut off the tip of his finger. He was dropped off at an emergency department. He was told to tell the providers there that this injury had nothing to do with his work. He did not have insurance, nor did he have workers' comp insurance. He was given 3 days of pain medicine, and the wound was closed. He couldn't work without this finger, and we don't know what happened to him. He was lost to follow up, and we don't know if he returned to the workplace or not. So as we move through our talk today, just think about these two different workers. And for this broccoli worker, let's think about what it means to be afforded fewer protections than other workers are afforded, to maybe speak a different language, to not have insurance, to not have workers' comp, and essentially to be looked at as a disposable worker. Because this is a CE event, we have nothing to disclose. And also the objectives for this event are, we're going to talk about the environmental and worker health risks, work-related health risks that contribute to illness and injury among farm workers, look at some strategies that to support cultural responsiveness and continuity of care for farm workers and their families, and look at some ways to increase awareness regarding the health and safety needs of farm workers and their families. I want to just begin with just a brief demographic overview. A lot of this information that I'm going to tell you comes from the National Agricultural Workers Survey. The worker population is largely male, although when I started working with the farm worker population in 2000, it was around 18% women. So we're seeing an increase in the number of women in the agricultural workforce over time. Still largely a younger population, with about 42% of farm workers under the age of 35. It's largely a Spanish-speaking population. Many of the workers are foreign-born, the most of them coming from Mexico and Central America. There's a lot of folks that are U.S. citizens and from Puerto Rico that also work in farm work. And about 42% of the farm workers surveyed did not have authorization to work. On average, we're looking at workers that have about a 9th grade education, and that has a lot to do about when free public school ends in sending countries. It ends between 6th and 8th grade in a lot of the sending countries. The mean and median individual income ranged from $20,000 to $25,000. And about 21% of agricultural worker families had a total family income below 100% of the federal poverty level. About half reported not having any health insurance, and 40% said they had not visited a U.S. healthcare provider in the last 12 months. I do want to say that the NAWS, that survey where that data came from, does not include H-2A workers, and H-2A workers have been in the news a lot lately because we're weakening some of the restrictions in terms of the protections that they're afforded and also their wage. But it's a program that allows U.S. employers to meet specific requirements and bring foreign nationals to the U.S. to fill temporary agricultural jobs. And this number has been of visas provided to the H-2A program has been increasing substantially with every administration and each year. And the challenge that we're facing right now is that a lot of the protections, which include you have to give your workers comp, you have to provide housing, you have to provide a certain wage, all of those are being weakened as we speak. All right, I want to just introduce you to Marisol. She is a worker who is working in the heat. And this is what she tells us. She said, it's hard work because the foreman constantly rushes us. Many workers have died in the fields due to dehydration or illness. I was picking chilies once, and a woman worker told the foreman she didn't feel well. The foreman took her out of the field, and 3 days later, it was 115 degrees out, and another young woman, just 21 years old, fell ill. We saw the ambulance taking her away because she had fainted. So heat is a real risk for many of our farm workers and workers in general. About 2,000 workers die each year in the US, and we estimate that 170,000 workers are injured. And this is a really important thing to think about and remember in our farm worker patients or farm worker communities or any of us dealing with workers who work outdoor. About 70% of the deaths related to heat happen in the first 3 days because workers cannot acclimatize accordingly. A recent analysis that was done looking at heat and injuries. So they did an analysis of all injuries and found that about 28,000 injuries per year were attributed to heat, and that these injuries would not typically be recorded as heat injuries. So slips, trips, and falls, almost in all industry sectors, that there were a number of additional types of additional injuries that they could associate with the fact that it was also extremely hot outside. So just adding to the risk of your regular injuries. The most vulnerable to heat-related illness and death on the job, it disproportionately strikes workers who are low income and Black and brown, and they're overrepresented in jobs with the highest rates of heat stress. So the likelihood of death from heat-related illness for construction workers is 13 times higher than the risk to the average worker, and for agricultural workers, it's 35 times higher. Climate and heat is probably our first, or heat is like one of our first climate related epidemics among workers. And what we're seeing, particularly in workers outside of the US, is chronic kidney disease of unknown cause. And it is the leading cause of death among working age men in certain agricultural communities in different parts of the world and Central America. And in El Salvador, chronic kidney disease is the second leading cause of death among men, including young men. And we think that it's a combination of heat and chemicals and contaminated drinking water, but mostly we're looking at heat as being the problem or the cause of some of this chronic kidney disease. MCN really takes a pretty holistic look at what it means to work in our current climate. And we know that when we think about it in bigger terms, even beyond the heat, that the climate is something to really think about and consider how it impacts workers and migrants. So just starting in the ascending countries, we know that the climate crisis can push migration, whether it's drought or wildfires or flooding that causes soil erosion and hurricanes. All those are going to push migration. In 2020, there were 2 Category 4 hurricanes that hit Central America. We were so focused on COVID, we barely noticed, but over 1 million people were displaced from those hurricanes. And then as workers move or migrate, they face a lot of really perilous environments in their path to migrate. Extreme temperatures during border crossings is an important health risk. So many of our immigration policies, particularly prior to 2025, really pushed immigrants further and further away from safe places of entry into the desert, and dying from the weather is the #1 reason that many migrants die on their way to the US. And in fact, the American Public Health Association has declared these kinds of border death, a public health crisis. We've stopped counting the number of deaths as of a couple of years ago, so maybe no more deaths are happening. I'm being facetious, but this is still a really important risk for workers. And then they work in industries where they're largely outdoor and are affected by hazardous conditions that involve heat, wildfires, flooding, and hurricanes. And often they're living in areas and that are affected by the same type of climate related events, and also where they're living. So their work and their living places are all impacting them. And these are important considerations to think about as we think about our farm worker population and other workers who are working outside. Pesticide exposure, both at work and at home, are important hazards to think about with farm workers. And then on top of these environmental related risks, there's just general vulnerabilities that farm workers face, and like thinking about our broccoli worker, the cultural and language differences, lower wages, the inherent dangers and health risks that come with working in agriculture, immigration status and migratory lifestyle are also going to impact the workers, and then lack of access to healthcare, insurance, and financial resources, and then lack of regulatory protection. And my background originally was in policy, so I love to share the path of the lack of regulatory protection that farm workers face. So when we think about our national labor laws that impact all of us in our workplaces, the National Labor Relations Act was a key piece of legislation that's still impacting us. Basically that allowed workers to unionize, but farm workers were excluded because FDR really basically made a deal with the Southern Democrats at the time to move the industrialized North out of poverty, and basically left the black sharecroppers alone and kept them out of the unions. And then that ability to unionize brought about the Fair Labor Standards Act. So that in 1938, we got minimum wage, overtime, got rid of child labor. There were many exceptions to this for agricultural workers. So there was not a minimum wage for agricultural workers. There was no overtime extension, and child labor is permitted in agriculture. And many of these pieces from the 1930s still impact farm workers today. While we've made some progress, obviously we have a union, UFW in California, Washington, Oregon. Other places are still trying to unionize, and there's still states that prevent unionization. So we call this overall this farm worker exceptionalism. And when we look at health and safety regulations, in addition to our labor laws, we see that farm workers are continued to be excluded. So workers' compensation, that's one thing that the mill worker had. He had access to workers' compensation insurance. Farm workers are not afforded the same type of workers' compensation in every state that other workers are. There are about, I think, 14 states that say that you have to provide workers' compensation to farm workers, and the same rules apply to farm workers to other workers, but there's many exceptions in the states around workers' comp. OSHA, when the OSHA Act was passed in 1970, farm worker advocates were like, oh, hooray, we can protect farm workers more. And it actually took a lawsuit and 17 years to get the first standard in place for agricultural workers, which was the water and sanitation in 1987. So today we still are impacted by exclusions, like OSHA can't look at farms with 11, or can't use federal funds. There's always a rider in there. Can't use federal funds to enforce the OSHA Act on farms with 11. They can only enforce it on farms with 11 or more workers, or farms that provide housing. And then another type of exceptionalism, which is a little bit nuanced, and I won't go into great detail, is that the EPA, which regulates pesticides, is the agency that's in charge of protecting workers as well, and not OSHA. And so that's actually an important consideration. And there's a lot of different, like, it's a risk-based standard versus a health-based standard. But at the end of the day, what it means is that farm workers are provided fewer protections than other workers. So how does this all impact farm worker health? We have their work, their physical health, their mental health, and their environment, and then these structural issues, discrimination, immigration status, language, continuity of care, regulatory issues are all overlaid on top of that. And all of that together looks at impacts farm worker health. So we wanted to just mention that the MCN really looks at different ways that we can address some of these structural issues, some of these challenges, through cultural adaptations, through culturally responsive education, looking at language and literacy level, addressing cultural health and beliefs, adapting for mobility, thinking about telehealth and electronic, just other types of communication. And also appropriate service delivery models for patient navigation, the use of community health workers, and coordination with schools and work sites and mobile units. And now I'm going to hand it over to N.A. And N.A., you just tell me when you want me to advance the slides. Who's going to talk about one of our programs called Health Network, which is a care coordination program for patients who move.
So yes, hi. Yeah, so I am going to talk a little bit more of Health Network. And Health Network strengthens our communities by opening pathways for patients to feel safe and equipped to engage the care of the need. So yeah, next. And here I am going to talk about a case study I'm recently working on. This case involves a 33-year-old man. He has type 2 diabetes and he travels with an H-2A visa from Chiapas, Mexico to Pennsylvania for work. And although he was not experiencing symptoms, he did go and do it like a random checkup. A glucose level was very high. He was at 429. Then the clinic attempted to control his diabetes, but his work contract was ending, so that wasn't enough time for him to manage his condition. So as a result, the clinic reached out to Health Network for support. I received the case and conducted him with the clinic where he now regularly attempts appointments. His diabetes is currently stable. He's taking some medication as prescribed and he's waiting for his return to work and continue to stay in contact with us and we're all supporting him. But I do want to note and take this that the clinic provided him with medication to take with him, but due to the short time available he did have, he didn't receive the proper education on the medication. So when he returned to Mexico, he was experiencing symptoms and he had many questions about how the medication, how to take it, and how it was making him feel. So unfortunately, the clinic did not have sufficient time to explain possible side effects or what to expect before his departure. And patient is in our culture. And see, the good thing about Health Network is that we not only put them in a clinic or set them up with an appointment. We also try to educate them as much as we can to let them know that it is very important for them to go visit the clinics. Uh, this patient in particularly mentioned that he was afraid because what was going to happen if he was diagnosed with diabetes. and then come back to the States, and for them not letting him, arrive or, work. So, I had to, tell him, we'll figure that out, but it is important that you take care of yourself. The health is very important. So things like that, they do fear, and we try to educate them as much as we can for them to have a better health. Yes. Next. So health network and the health system, we help in patient understanding, and we transfer medical records, schedule appointments. Transportation, we do help on the transportation, and figure out if they are insured, how for them to go to the clinics as well, connect with the health centers and provide them as much resource as we can, or what they need, and trust the partners in health. I also want to add that we have assisted in providing help. Well, we started with tuberculosis disease, but we're doing HIV, we do diabetes, prenatal, and we also do the pediatric care. So that's a little bit of what Health Network also helps with, and we do educate them as much as we can with that. And next. So for this essential role, like Amy mentioned in one of her slides, we are patient navigators, we are community health workers, and we continue to expand across, access, to build trust, to get as much as the health, improve the health outcomes in our community. Our health network team has gained certification as community health workers. We are also working on our certification to become community health workers instructors. So this means we have the opportunity to expand the population we served and provide more resources. So not only we try to help our migrant farm workers families, we also try to work in our community to provide any resources and education. Also, helping them assist with an appointment, or anything that they might be struggling with. Language barrier is one of the important things we also try to help with, because we understand sometimes that can be a difficulty for our patients. So yes, that is more or less a little bit of what Health Network is built, and the community health workers that we have here, and we do.
Thank you so much, NA.
Yes, thank you.
So I just want to round out NA's talk with another case that actually happened during my time at MCN, and some of you may remember this. But I want to sort of emphasize sort of where that role of the community health worker comes in. And so I want to tell a story about Carlitos and his parents and other kids that were impacted by the work that they did in agriculture. So essentially in 2004 and 2005, there were three farm worker families that lived in the same camps and worked in the same fields and were exposed to similar pesticides. They were working in North Carolina and Florida. And within 3 months of each other, these women gave birth to babies with severe birth defects. One baby, Carlitos, was born without any arms and legs. Navarette, whose parents lived about 100 feet away from Carlitos's family, was born with a cleft lip. And then another baby who was born 2 days after that, Navarette, she was missing a nose and ear and had no visible sex organs. And at first this child was named Jorge, but hours later was renamed Violetta after a more detailed examination. And she died 3 days later from her massive birth defects. This is happening in a very short period of time, and then later we found out that there was a fourth baby in with that whose parents lived near these other families, and that family that baby had similar birth defects as well. And so, the reason I'm sharing this is I always like to ask, how do we know about these birth defects? And so I'd like to think that we had like an amazing surveillance system in place where we were reporting such birth defects, that maybe there was an astute clinician that was delivering these babies were all delivered in the same community, that someone was noticing it within the system that these babies had these severe birth defects, or that we had an electronic health record system that maybe would have flagged it. But we know about these cases and that the similarities of these women and the time period of when they gave birth because of a community health worker. It was a community health worker that was going to the camps that was like, this is not right that we have so many birth defects. And then she went back to the health center that she was associated with and told the clinical team there about what had happened. So this is a really, it's dramatic, I know, in terms of the severity of the birth defects, but the point of it is that we really need this whole team, and the role of the community health worker is as critical in some of the care as other parts of the healthcare team. All right, I just want to round us out with some policies. When we've talked about the lack of policies, I do want to sort of give us some hope that we've had some changes over the years. Heat. I talked a lot about heat. We did not have a national heat standard. I know many of you on this call have been involved with pushing for a national heat standard. We have 6 states that have a heat standard, and Virginia just passed the law this year, and so their regulations will be issued, I think, in 2027. So, and there's some other states that are trying to work on this. Nevada also has one, but it's not a very strong standard, so I don't put it in this slide. But little by little, our states are making progress, and hopefully we will have a strong national standard to protect workers from the heat one day. And then just a note that as our climate changes, as we're experiencing more high heat days, a logical response to the heat is harvesting at night. And harvesting at night is a important solution. However, I just want to note that it also comes with other types of risks where we can increase the injuries, we can increase the exposure to vermin. The varying shifts and irregular schedules can be harder on workers. Childcare might be an issue. And then the possibility of workplace violence and workplace sexual violence increases in the night as well. One of the things that I've worked on throughout my career has been the Worker Protection Standard, which is the regulation that EPA oversees, that is the regulation intended to reduce the risk of illness or injury to workers and handlers resulting from occupational exposures to pesticides. And just a little history, the first Worker Protection Standard was issued in 1974. That's because we were saying to OSHA, do something. So the EPA was like, no, we'll do something. And then in 1992, we had some major revisions, but it still was a very weak regulation. So I came on the scene in 2000, but people had been working since the 1990s to improve the Worker Protection Standard. I'm happy to report that 15 years later, into my career working in this from 2000 to 2015, we did get a comprehensive revision to the worker protection standard, and I'm really proud of that work. It was fully went into effect in 2017, and then it was fully finalized by 2018. And the nice part of this story in this day and age is that we have been able to maintain what we put in place in 2018. And so that feels still like a victory today, several years later. But it is the revisions that were made in 2017 and 2018 really did make it a stronger standard, and offered some really important improvements. So the worker protection standard and heat standard are still really important regulations that are protecting our workers. Though we're talking about environmental hazards, I just thought I'd be a little bit remiss if I just didn't bring in ICE and enforcement, immigration enforcement. And I just wanted to refer you back to a study that MCN did in 2025, which is really echoing everything that we're reading in the news. We surveyed about 691 providers across 30 states, providers that were caring for immigrant and mixed families. And basically the key findings, and we're continuing to see this today, is that 84% of the folks that we surveyed, they saw reduced patient visits. Reported 26% were reporting direct care disruption, and then 7%, and when we did this, we're reporting ICE or Border Patrol presence in clinics. And so we're continuing to see that, and that continues to impact the health of our patients. The type of care that was most affected at the time that we did this was preventative care, including checkups and vaccinations, chronic disease management, and mental health services. And you can read more about that on some of our Substack, that I'll have a link to that later on. But I just wanted to mention that this is affecting all of our communities. When I talk about the demographics, we talk about the demographics of our population. We can't ignore the fact that the ICE and ICE enforcement is impacting the health and safety of our farm workers. Just a little bit about Migrant Clinicians Network. Our mission is to create practical solutions at the intersection of vulnerability and migration and health. And our work is pretty broad, from a program that NA so beautifully described, our health network program. We do a lot of resource development, continuing education, worker health and safety programming, training and technical assistance. And we also have a program called Witness to Witness, where we're really acknowledging the moral injury and the trauma that our clinicians are facing, not just in our current environment, but we started working on this project during COVID, where both our population that we serve and the clinicians who serve them were two of the populations on the front line of COVID. And now we're into a moment where our clinicians are again on the front lines in terms of immigration enforcement, and they're witnessing trauma being impacting their patient population. Our primary constituents are our primary care providers. We work very closely with the federally qualified health centers, and community health workers and outreach workers, as well as clinicians and other healthcare delivery sites. We have a ton of resources. I welcome you to go to the MCN website, migrantclinician.org. I talked about heat, so we have a specific clinician's guide for heat. We have a lot of resources. These are just our pesticide resources that to help clinicians talk about ways that workers can protect themselves, ways that they can protect their children, and then also ways that women of reproductive age and thinking about ways to protect themselves from pesticides. And so I also mentioned that there are different regulations and different laws regarding workers' compensation and pesticide reporting. And so we have an interactive map that will help you figure out what the regs are in your state for reporting pesticide exposure, as well as workers' comp, and then all links to our clinical tools and our patient education tools. And then also here's some information about our health network and enrolling patients into health network. You can get more information or help enroll them. And then also I mentioned earlier, we're on Substack and today is World TB Day. We have a beautiful piece written by our chief medical officer on tuberculosis and a patient that was receiving some treatment, and he lost contact with the patient because the patient was detained. And so he talks about that case and what that means for the TB and controlling TB. And so we encourage you to connect with us, access our resources, access our trainings, get updates from the field, and we welcome you as using our resources. So I'm gonna stop sharing here, and then would be happy to entertain questions.
Amy, this was incredible. I have to be the first to say thank you so much, and Enya as well. Looks like we have a question from Barb. Go ahead.
You're on mute.
Fabulous, and you're getting all kinds of hearts and stars and happy hands. Anyway, I'm Barb Sattler. I work in California. I'm co-chair with Matt of this committee, but we also have a group of nurses out in California that are working with several different farm worker organizations. And so a couple of questions for you. One is, where does your funding come from, and is it stable? The other is whether the National Ag Workers surveys are still being supported because of what's going on in the universe. Um, and also, could you elucidate, because there's a lot more to say about the H2A program, and I'm wondering if you wouldn't mind talk about what these, slavery programs are really about. So that would be terrific. So thanks.
All right.
And
Funding. Yes. So MCN receives about 75% of its funding from the federal government. And it's been a challenging time, and we're walking a lot of tightropes. We've really I think we've done a really good job at trying to be responsive to new requirements that the federal government is putting on us, as well as being true to our mission. And that's just every single day. It's a balancing act, but we know that we have to maintain that. So we are turning to foundations. We're much more reliant on donations from individuals, and trying to diversify that funding base. That's our funding story. And then we're, a core piece of our funding that we've been getting since the 1980s, right around our inception. That funding, we've successfully recompeted for that funding every 3 years. And we now are being forced to compete in a very different way in a notice of funding opportunity that doesn't mention farm workers once. It mentions medically underserved populations. And so, and we still have our name of Migrant Clinicians Network. So we're taking the big, bold move, and we're still applying for that. We've established really impressive partnerships and to apply for that. But we know that we're in a really competitive environment. So we welcome, also different partnerships. Like we're looking at, some of the rural transformation money and different alliances with different groups to really get us through that. So that's our funding story. We got yanked from some funding, we got some funding back. So it's been a little bit of a roller coaster, and it's really hard facing internal stress at work while we're facing all these external threats as well. Your second question was the H-2A question?
Well, the one in between was the National Ag Workers Survey.
Oh,
Can we expect that to continue?
I'm sorry, I don't know where we are right now, but it is being proposed to be discontinued, and I don't know if that discontinuation officially occurred. It's, as you all know, it's been really confusing. Like things get cut, things get taken away. There's a lawsuit that happens, it gets back, and so I'm sorry, I don't know exactly where we are, but do know that it is very threatened. And it is not safe, and it's not the greatest source of information, but it is our only source of information on a national level. So we are really dependent on that to understand some trends for it. And then the H-2A program. So the H-2A program, on paper it sounds great, right? Oh, it's a visa program. It lets people come into this country with some kind of legal way to enter, and they can work on the farms and get paid. And so yay, that sounds great. So even before this moment in time, there were problems with the H-2A program in that I work at Migrant Clinicians Network. If I'm really unhappy with how I'm being treated at Migrant Clinicians Network, which obviously I'm pretty happy since I've been here since 1999, but if I'm really unhappy, I can vote with my feet and leave and look for another job, and I don't have to, it doesn't matter about this visa. When H-2A workers come, they're completely tied to their employer.
Wow.
So they're very vulnerable to exploitation. And they're vulnerable to not only in the moment, but they also don't want to, there's no incentive to report violations or their injuries because they also want to come back the following year. So they don't want to be blacklisted. So there's a lot of challenges, and we've had some recent horrible cases where there was, we showed that there was actual slavery. People were like, they took their documents from them. So it wasn't a perfect program prior to 2025. And now what's being happened is some of the requirements that go along with the H-2A program, such as they have to be provided housing. Like the wage should be equal to the wage in that area. They shouldn't, like, it's not good for any workers, both US workers and workers on visas, for the visa workers to receive lower pay. Like that's a bad system. And so the way that they're analyzing that pay is being proposed to be changed and is changing so that the anywhere between $1 to $7 an hour less than they would have gotten under the previous program. And then I think there's also some housing, like no longer I think the workers can be charged for housing. So not a lot of incentives for the workers to like come through that program at this point. Some might argue that it's going to help the farmers. I don't think so. I think we're still going to look at some important labor shortages, but from a worker protection perspective, it's taking a program that had a lot of challenges and problems and was ripe with abuses to make it even more abusive. So that's unfortunately what we're looking at with the H-2A program.
Yeah, thanks. I wanted you to elucidate because it is so problematic and it sounds on the face of it like, somewhat innocuous. So thank you.
Yeah.
Yeah, that was great. I see Tom has his hand raised. We've got a couple more minutes.
I always have questions, so I'll defer to Amanda and ask mine if there's time.
Amanda, you're up. You there?
Hi, yes, I'm here. I wanted to ask a question. I know I heard the previous speaker mention about the birth defects. So I wanted to know if that's from the chemicals that they used in their job, and how does that affect us who consume the food?
That's a great question. So the Department of Health in North Carolina and the Department of Health in Florida both did sort of extensive studies and I don't have the link right now, that looked at what was the potential association between the exposure and the birth defects. And for the child born with a cleft lip, they felt like that they couldn't, that was really hard to link because the potential hereditary pieces of it. But for the babies born without any arms and legs, and that fourth baby that was actually an aborted baby that had similar issues in Mexico, those were the birth defects that the North Carolina Department of Health, I believe, found an association between the exposures. And so I believe, if I remember correctly, that the Florida Department of Health did not have similar findings as the North Carolina one. But the bottom line is that they were able to show that pesticides that do cause birth defects were used, and the women that were working in the fields at that time and living near them were likely exposed to some of those chemicals. It's really, really hard. These studies are really, really hard to show those kinds of linkages and association. It's never like direct, like, oh, this pesticide was used on ABCD date, and then this was the point in gestation where they were exposed. It's very, very complicated, and they're doing it after the fact. So I felt like I did not look at those studies before I shared the case study, but I do remember when I read it that North Carolina just did an outstanding job in looking at those associations. And Carlitos actually got a really huge settlement, and he's 20 years old or so today, and does give different talks around the country in terms of or has given some talks at various points about his situation. And so the challenge is that in some ways, pesticides are actually very well studied. Like we know more about pesticides and in the registration process than we do about a lot of other chemicals, but we do not use the precautionary approach with pesticides. They are put on the market, and then we're like, oh, well, this is what happens. And then it's really challenging because we saw the need for women. Women are working in agriculture, and the number of women are increasing in agriculture, and we don't want to like take women away from a source of income, but we also want to make sure that they are protected. And so really looking at the types of chemicals that are used and understanding that and having a much stronger regulatory approach to it would be a way to go. But I want to like just not have us walk away with like, oh, women shouldn't be working in agriculture when they're working in, when they could get pregnant. That really is a bigger question, but looking at how can women protect themselves and how can they work in fields where they don't have to be exposed to chemicals that cause birth defects. And as far as the food that we eat, another really good question. But and that's kind of like another, we don't have enough time for that in this discussion. But there are a lot of challenges in terms of protecting the consumer from the chemicals that are used in the food. But our bigger concern, because of the depth of exposure and the length of exposure, are the workers and the families that are living nearer to that. So people should not eat fresh food or fruit and vegetables because they're concerned about the chemicals. But also knowing that there are possibilities of exposure when we're using these chemicals on our fruits and vegetables. And
Wow.
Robin's on this thing. She could probably say a lot more on this topic than I'm saying right now to answer that question. But I'm trying. I know it's like there's regulations and there's a whole other discussion around it.
Well, I was just gonna put in the EWG just came out with their Dirty Dozen Clean 15 lists today. So I was just gonna pop that in the chat.
Thank you.
That would be great. Yes. Looks like we have.
Can Robin just say what that is? Because there
Oh,
may
I'm
be
sorry.
other.
The Environmental Working Group does this shopper's guide every year. The Dirty Dozen is the top 12, or there's 14 this year of conventional pesticide. It's the ones that have the most used pesticides. And so if you can buy those things organic, that would be preferable. And then the Clean 15, if you don't have an option, then it's okay to buy those conventional treated um, produce or products. So,
Thank you,
um,
Robert. That's helpful. All right. Well, we are right at time. I think we want to close with Kara. Do you have any final things to say? We want to thank our speakers. This has been excellent.
Yes.
Round of
Just
applause.
Yeah, thank you. Thank you both so much to Anae and Amy for your fantastic presentations and the engaging discussion. Just a reminder, look out for an email from me in the next couple days if you would like to get CE credits in the or nursing continuing education. And I will also send out a recording in that email. And then just a reminder, we do have coming up on June 3rd a webinar that will be focused specifically on food security. So I'm going to pop the registration link in the chat, and please join us there. But thank you, everyone.